So I'm just going to run through various aspects of bladder cancer. I know there are patients and family in the room who are in different positions in the bladder cancer spectrum, whether muscle invasive, non-muscle invasive, and it's not going to be comprehensive. It's going to hit some of the highlights, and some of what's new, some of it's not new. Some of it is sort of trying to put things into a framework that you can think about the disease. And I'll try not to go too heavy on the data, but it's always hard not to. The first thing that I think surprises a lot of patients and family members is how common bladder cancer is. Amongst men, it's number 4. Amongst women, it's number 12. Overall, it's number 5. And most people have never heard of it. If you don't have it or have a family member with it, most people have just never heard of it. And of course, everyone knows prostate, lung, and colon. We talk about it a lot. You hear a lot about it in the media. But for some reason, number 4, bladder, sort of disappears into the conscious of people. So it is a very common disease. If you think that a lot of patients with bladder cancer live many years with their bladder cancer, so especially the non-muscle invasive bladder cancer patients, it's one of the most prevalent diseases. So that means there are just a lot of patients. If you're saying incidence, it's the new cases per year, but just the number of cases out there is an extremely large number. We know there's this male-female predominance, which in the past has been due to exposures in the workplace, for example, and smoking. Women, of course, have caught up with smoking. They've caught up with workplace exposures, but the 3-to-1 ratio remains, so there's some biologic differences there as well. And of course, we always highlight that it's the most expensive of all cancers if you take the cost per patient per lifetime. And a lot of that's due to the invasive nature of the follow-up. So all of those cystoscopies that all the patients in the room love, and all the various treatments, intravesical therapy where you're putting drugs into the bladder, repeated trips to the operating room. Cystectomy, of course, is an expensive operation because it takes a long time and the recovery is slow. So it has a big economic impact, which we should also remember in just the big picture. It is a disease of the elderly. It doesn't mean that everybody who has bladder cancer is old, but it is remarkable. If you look at all cancers, the median age for bladder cancer is older than for any other cancer, which has impact, of course, on how we treat the cancer, because older patients are not necessarily eligible for all the most aggressive things we would like to do. And so we always have to balance health, general health, age, and the aggressiveness of treatment. And you can see here these are in different ethnic groups, which is not the point of this slide, but more just to show you how the incidence really takes off in the 60s, 70s, and 80s. So it's a very common cancer, especially in older patients. Now, overall, we divide bladder cancer into 2 big groups. This diagram shows you the differences in the stage of the cancer. So stage is how extensive it is. And in bladder cancer, that usually means how deep it invades into the bladder wall. And so we distinguish the non-muscle invasive bladder cancers that really sit on the surface. The TIS, carcinoma in situ, are flat lesions that they're cancer cells that just spread on the surface of the bladder. It can be very tricky because you don't necessarily see them, so they're more difficult to monitor. The TA tumors are like polyps. They're very much like colon polyps, which people are familiar with. You wonder why they're not familiar with the same in the bladder, but they really they stick up from the surface and there's no invasion, whereas the T1 tumors actually are starting to invade. They're really the in-between between the non-invasive and the muscle-invasive. If there's a T1 bladder cancer, we immediately get a little bit more anxious that it could turn into something much worse. So about 75% of patients or cases are non-muscle invasive. The other 25 are muscle invasive. And typically we're able to preserve the bladder. The transurethral resection, so the TURBT, is a big part of management. And then as needed, we put drugs into the bladder, whether it's chemotherapy or BCG. So the other half are the muscle invasive, or not the other half, the other quarter of cases are muscle invasive bladder cancer. For the most part, patients will present with muscle invasive cancer. So the first diagnosis is muscle invasive, although some will go from non-muscle invasive to muscle invasive, especially the T1s. And this is where the treatment becomes a lot more aggressive. This is where we're generally talking about removing the bladder. Radiation is an option in some patients. We talk about giving chemotherapy before removing the bladder, so neoadjuvant chemotherapy, sometimes afterwards, which is adjuvant chemotherapy. And the stakes are much higher here. Muscle-invasive bladder cancer will spread to the lymph nodes and other organs if given the chance. So we want to treat this as quickly and aggressively as possible. So I'm going to run through various things here in the context of non-muscle invasive and then muscle invasive disease. So I'm going to talk about enhanced cystoscopy, which is something that is available widely in the US and Europe and only now coming to Canada. I'm going to talk a little bit about urine markers. We'll talk a little bit about intravesical therapy, and then also what's going on after BCG. So BCG is a very effective treatment. We don't necessarily want to replace BCG, but we want to be able to add on to it. And right now, there is no standard of care after BCG other than removing the bladder, but there are a lot of very interesting drugs in the pipeline. I'm going to spend most of the time on non-muscle invasive disease, and whenever Tammy yanks me off the stage, I'm just going to fast forward to the end and show you a couple of things. But if we have time, in muscle invasive bladder cancer, I'm going to talk a little bit about predicting response to chemotherapy, and then also about immunotherapy, which is the latest rage in bladder cancer, but right now is really only in the latest stages of the disease in clinical practice, so in the metastatic patients after chemotherapy. So non-muscle invasive disease, everyone in the room shudders a little bit when they see this, but this is our go-to instrument of torture of choice for bladder cancer detection. But the problem is it's not really as good as we would like it to be. We do miss cancers with cystoscopy, as is evidenced by various different things. So we always look inside the bladder again 3 months after resecting bladder tumors, and we will find recurrent disease depending on there's widely varying numbers in the literature, but between 5% and 45% of the time. And that really means, in most of those cases, that we missed it in the first place. Doesn't necessarily mean there was a mistake on the side of the surgeon, but it was either very flat or otherwise inconspicuous and it was missed. And those are lesions that we would like to detect, obviously. Now, anybody who has a T1 tumor, so invading into the first layer of the bladder wall, we will always take them back and re-resect. That's just a matter of practice because we know that in approximately 30 to 50% of the cases, we missed something the first time. So that right there tells you that it's imperfect if we already plan to go back. It sure would be nice just to do it right the first time. And then what I'm going to get to is the fluorescent cystoscopy, which in studies has shown that approximately a quarter of patients will have lesions that you can actually see if you have the enhanced technology to see better with fluorescent cystoscopy. So this is a slide that Fred Witches in Holland likes to show. You can't find what you can't see. Dutch humor. So when we're talking about enhanced cystoscopy, we're just talking about seeing better. If you can see better, you can resect better. If you can resect better, there should be fewer recurrences. So there are two systems out there. One is called narrowband imaging, which just means that you're taking the whole spectrum of colors you can see up top here, and you're applying filters so that you only see blue and green. I'm not colorblind. And with the filters, what it's really doing is highlighting blood vessels. And if you highlight blood vessels, it can help distinguish cancer better from the background. The nice thing about this is it's a flip of a switch on the cystoscope. We, for example, have it in our office where we just hit a button. Usually we hit it accidentally. And it flips from white light to narrowband, and you can flip right back again. And the evidence here is not as good as the fluorescent cystoscopy, meaning just that the studies haven't been done yet to really demonstrate that it's hugely beneficial. But it's just there, so it's easy to do. It doesn't cost anything, as long as you have a newer system. The other option, which I think has gained a lot more attention because there are a lot more studies, so the level of evidence is much better, is the fluorescent cystoscopy. So this is something where the patient will have a reagent put in the bladder approximately an hour ahead of the bladder tumor resection. So it's done at the time of surgery. It's not done in the office. And so it sits in the bladder for at least 30 minutes. It's then drained out. And then while we're in the operating room resecting the bladder tumor, we can, again, just flip a switch and it'll go between fluorescent and white light. And bladder tumors typically light up very pink like this. I mean, it's very obvious, right? There's nothing subtle about that pinkness. And this is the same area of the bladder wall, and you can see on this side that you would never suspect anything. And this is very typical for a carcinoma in situ lesion. So it's flat cancer cells on the surface that visually you don't see with normal white light, but with blue light you do. And so it greatly enhances our ability to detect more cancer. The downside, of course, are the logistics of having to put it in the bladder beforehand and the cost of the agent that goes inside the bladder. And those are the things that we have to overcome. This is just another example where white light looks fine, nothing to do. Blue light, you have this little tiny thing that you would want to biopsy. And so what is the impact? Well, the impact in many trials, not just one trial, is significant. We do detect more tumors that are missed on white light. We do a much better job of detecting carcinoma in situ. So up to 1 in 5 patients will have carcinoma in situ diagnosed or detected with blue light that is missed on white light. When we go back at 3 months, we will see recurrent or persistent tumors in fewer patients. Most importantly is that the recurrence-free survival is better. So the number of patients who get out to a year or 2 without a recurrence is higher because we resected it better in the first place. I should add also, with better detection of carcinoma in situ, that of course can have an impact on how you treat the patient. If a patient has carcinoma in situ, you're going to want to give them BCG. If you don't detect that carcinoma in situ, you might not treat appropriately. So they're very early signs, a little bit vague, that it might reduce progression to muscle-invasive disease. I would say this is, the data is not really mature for that. There's no implication that, there's no data to say that it saves lives or anything, but the rest of this is all important. If you can prevent recurrences, that by itself is valuable. The one caveat is that these trials were all done without the single dose of chemotherapy. Most patients should get a single dose of chemotherapy after the bladder tumor is resected. And the trials, for whatever reason, were all done without that. There was one trial in the UK where they actually did the chemo the way we usually do and added in the blue light, and there was no benefit. So, but we would say that blue light is a lot safer and a lot better for the patient than a dose of chemotherapy. So if you're going to pick one or the other, you would want to do the blue light, and the cost is about the same. So I should say here in BC, it is not yet available. I mean, it is available in Canada, but the question is always who's going to pay for it. Government, of course, doesn't want to pay for it. It's up to individual hospitals or health authorities to pay for it. And so we're trying to arm wrestle with administration at VGH to pay for it. Toxicity is 0, so there's essentially no side effects. And I mentioned the cost is about the same as the chemo. So the latest news in this regard too, I mean, we're still trying to get it into the operating room. Meanwhile, in the US, they've published a trial or presented it at one of the large meetings that you can actually do flexible cystoscopy in the office with blue light. Of course, different equipment needs, but you can do the same thing and it will enhance detection of bladder cancer. So this is something that is going to migrate from the operating room to the office, and you're going to have better detection in the first place, which has potential advantages. So I'm going to move on to urine markers. Urine markers is one of the big panaceas in bladder cancer. I mean, it just makes a lot of sense. The tumors are surrounded by urine. You should be able to detect something in the urine that tells you if cancer is there or not. So mostly for detection, it seems like we should be able to do it. One of the main, I'm going to just go over sort of the 2 scenarios where we would want good urine markers. One is the patient who is referred in with blood in their urine, which can either be microscopic, so microhematuria, or it can be visible, gross hematuria. And the microscopic hematuria, it's only about 1 in 50, maybe 1 in 40 patients who's actually going to have a bladder tumor. And we have to scope every one of them to diagnose that bladder tumor. So it'd be really nice to have a urine test that is reliable enough that we can say we do not need to do cystoscopy. And that, of course, we would match to the patient risk factors. If it's an 85-year-old male who's been smoking for 75 years and has gross hematuria, then chances are no urine test is going to prevent us from looking in that bladder. But if it's a 45-year-old female who has no smoking history, then we would really like to avoid the cysto because it's not likely to show something. So that's one of the big focuses of marker development. The other is, of course, patients who have bladder cancer and are getting their cystoscopies every 3 months, every 6 months, once a year, however frequently it is. It would be really nice to replace some of those cystoscopies with a simple urine test. And even if we can't replace them, of course, we miss things, as I highlighted in the first part. We miss things on cystoscopy. So if we have a urine test that helps us see things or detect things that we don't see, that, of course, would also have a huge benefit. The only marker that we're currently using in routine practice in Canada, but also in most of the world, is urine cytology. So this is where you just take a raw urine sample, you spin it down in a centrifuge, and a pathologist looks at the cells after staining them under the microscope, and you can get a collection of cells like you see in the panel there, and the pathologist has to tell us cancer cells, yes or no, and of course it can be very difficult to determine. If cytology is positive, it is usually very reliable, so it doesn't say cancer if there's no cancer there. It's only good though for high-grade cancer. It's very good for carcinoma in situ. That's actually why we use it, so to detect the lesions that we don't see. And it's a non-invasive test, which is better than cystoscopy in that regard. But the problems are that it is horrible for low-grade, so it does not detect low-grade bladder cancer, and the vast majority of patients have low-grade bladder cancer, and there's just no help in those patients. And the guidelines actually say do not use it in those patients because it's a waste of time and money. It does depend on the expertise of the pathologist who's looking at it, as do so many things depend on the expertise. And then we have so many reports where it's called atypical. I'm asked several times a week what to do about an atypical cytology, and the bottom line is we ignore it because we could not possibly chase all of these atypicals. So we want something that is easier, better, faster, cheaper. There's been so much research going into urine markers, trying to come up with something that will help replace cystoscopies. And the main obstacles are that most of the tests up to now have been a single protein. One of the best tests is called NMP22. It's a protein found in the nucleus of cells, but it's a single protein, and it's just not likely to pick up all patients. The other thing is the way that studies are done. If I told you at the beginning that about maybe 5% of a population with micro and gross hematuria are going to have bladder cancer, yet the studies are done where 50 or 75% of the patients have bladder cancer. And it totally skews the results, makes the test look great, gets everybody excited, and then doesn't validate when you do a proper study. And then the biggest limitation is that really most markers haven't gone beyond these initial studies and actually tested whether you can skip cystoscopies or do something different by using the marker. So what would the actual clinical utility design be? So now this is a question I want people, you'll have to pay attention now because I want you to raise your hands for this one. So the question with a marker, of course, is how good is good enough? If we can give you if I can quote you a number that if the urine test is negative, I don't want to do the cystoscopy because I'm only going to miss a small percentage of tumors. What percentage of tumors do I have to detect? So if you've had a prior low-grade tumor, so nothing overly threatening, and I tell you there's a new urine test that I'm going to offer you instead of cystoscopy to monitor your bladder, what percentage of tumors would the test have to capture for you to want to do it? So who says if it doesn't capture 100%, I'm not having the test? Raise your hand. Okay. Who says, okay, greater than 95% is good. I'll take a 5% risk that we're going to miss something. A few. Okay. Greater than 90%? Okay, more there. Greater than 85? Okay, good. What about anybody lower than that? Okay, it's split very evenly. So this study was done in the US by the group at Sloan Kettering. They took 200 patients. They weren't necessarily low grade. That part I made up, but and they used some gamble methods, their research methods around this. And they wanted to look at the minimal accepted accuracy, which is also a little bit different than sensitivity. But basically 75% of respondents wanted a sensitivity greater than 95%, which is probably not possible. So, that's one of the reasons also why the urine markers haven't gone beyond preliminary development. The other 21%, or most of the others, wanted at least 90%. And interesting side note was men who found cysto painful were more likely to tolerate a lower level, which I thought was very insightful. So there is a lot of excitement in this area because there are a lot of new markers being developed. I mean, I think we all got a little bit tired of talking about urine markers because it just wasn't going anywhere. But now we have a bunch of new markers, and out with the old, in with the new. Most of the new markers are now genomic markers. So looking at RNA, DNA, especially DNA methylation in urine, looking at multiple markers instead of just one. And there are different trials underway where they're actually being evaluated in a more reasonable fashion in a very high number of patients. And here's just 4, just to mention them. I'm not going to go into any detail. But there's a lot of excitement in the urine marker field. So intravesical therapy is a big part of non-muscle invasive bladder cancer. And I want to highlight to you how we need to stratify risk in all patients. So not all patients are the same, even within non-muscle invasive disease. And everybody needs a form-fitting treatment. Now, it all starts with a TURB, T for better or worse. I'll get past that picture quickly. We will resect tumor and then look and see what we have. And to risk stratify, we can look at all of these parameters. So we can see how big is the tumor, what stage is it, how invasive is it, how many tumors, is it one or is it multiple? Is it the first tumor or have there been prior tumors? If there have been prior tumors, how many, how frequent? Is it high grade, low grade? That's a big thing, right? That's the biggest predictor is high grade and low grade, how aggressive it looks under the microscope. And then if there is carcinoma in situ along with whatever else you're seeing. And you can get a very elaborate score from this, but of course, it takes time. You have to sit down on the computer, plug in all these parameters, and ultimately it's not used frequently in clinical practice. So what we do use, though, is more of putting patients in bins. Everyone has to go in their bin, low risk, intermediate risk, and high risk. So low risk is a single tumor for the first time that is low grade, less than 3 centimeters, and this is actually the vast majority of patients. So a lot of patients are low risk. It's 50%. I guess it's not the majority, but well, barely the majority. High risk is anything high grade. So again, grade is the biggest determinant of outcome. So any high grade tumor, any T1, so invasive into that first layer, the hitch there is that almost any T1 tumor is high grade anyway, so it's sort of the same thing. Carcinoma in situ, by definition, is high grade. So bottom line is anything high grade is high risk. Everything else is in the middle. So the intermediate risk patients, which is about a third of patients, are the low grade tumors that keep coming back, or they're large, or there are several of them. And so the treatment is based on these risk categories. Just the numbers. So if you're low risk, you have an exceptionally low risk of turning into anything bad, although there's still a good chance it's going to come back, about half of patients. If it's high risk, about a third of patients will actually progress to muscle invasive bladder cancer. So that's a big deal, and most patients will recur. So the low risk patients, it's a matter of resecting the tumor, putting a dose of chemotherapy into the bladder at the time of resection, and then watching the patient with cystoscopy, and not doing too many cystoscopies. So I think in the past, urologists have watched too closely and done too many cystos. Right now, the recommendations are scope at 3 months. Everybody gets scoped 3 months after TURBT. That's just standard for everybody, because it really helps you judge the risk moving forward. But if you have a low-risk tumor, that first cystoscopy is negative, then you get it once a year for 5 years and you're done. Used to be 10 years, it used to be every 3 months, every 6 months. It's really decreased because we know that we don't need to be doing as much as we were. And some patients, of course, want you to do more, but that's also not a reason to do more because it is invasive and there are potential complications. So in the intermediate risk, again, this is the big mix. There's a bunch of stuff in intermediate risk. And the lower end of the intermediate risk means you're just having occasional recurrences, less than once a year. They're often small. The small ones we can actually zap for us in the office, or just in the usual cysto suite from most places in the hospital. If you need to, you go back to the OR and you resect, and you do your single dose of chemo again, but you're not doing anything more than that. If it's more frequent, or they're larger, or there's a bunch of them, then we start talking about chemotherapy or BCG into the bladder. We do it for a year, so chemotherapy has to be given for a year. It is often not. Intravesical BCG, only for a year in intermediate risk, but for 3 years in high risk, as I'll show you. So there are a lot of nuances here, and it really depends where you fit into the puzzle. So the frequent tumors, bigger than 3 centimeters, and so if you have all 3 of these things together, you're automatically in the high risk category, and you should have BCG, or you're treated like you're in the high risk category. So again, you can see it gets complicated, it gets messy, but it's important to distinguish. High risk then again becomes very clear. In general, patients with high-risk disease should have a re-resection. There are exceptions, but I'll just put that out there. So we go back to the operating room and re-resect again to make sure we didn't miss something, because we know that we often do, and we know the results will be better if we do. It results with intravesical therapy. And then we give BCG, and the BCG has to be over 3 years. Patients are always surprised, after 6 months, 12 months, whatever, that I continue to threaten them with BCG. But those are the standards, and we have to do it. And it's one of the things that is followed the least well, shall we say, around the world as far as following standards of care. Cystoscopy is frequent in these patients. We want to find recurrence early and treat it aggressively. In some patients with T1, high-grade T1 tumors, we can say that they're not only high risk, they're very high risk, and we should think of cystectomy up front. And we certainly do this on a regular basis, and not doing it really puts the patient at risk for progressing to something much more significant. So if you have high-grade T1 disease that is multiple and large, you'll think of cystectomy. If there's CIS present as well, you usually will not, but it is an additional risk factor. Lymphovascular invasion means that the tumor cells are actually seen in the little vessels in the bladder wall, so lymphatic channels. That is seen as an indicator. If they can get into the lymph channels, they can potentially spread to the lymph nodes. So it's sort of the first level of spread. So if a patient has a high-grade T1 and lymphovascular invasion, I don't talk to them about BCG. I say you need your bladder out. And so that's a very important one. If it's very extensive invasion into that first layer, the lamina propria, then we'll talk about cystectomy. If it's anything other than the usual type of bladder cancer, we'll talk about cystectomy. And if it's in a diverticulum is an outpocketing of the bladder wall where there is no muscle backing. So the next layer after the first layer is the fat around the bladder. So it's impossible to tell if it's muscle invasive or not, and we will certainly be more aggressive there. And if we do the re-resection, so if I do the resection the first time, I think I got everything, and I go back and I find more high-grade T1, I know that patient's risk of progression is about 75%. So it's 75% of cases are going to turn into muscle-invasive disease. I think that's a very good reason to remove the bladder. So what is new in intravesical therapy? Not that much. The single dose of chemo that we give at the time of TURBT is usually mitomycin across the country. It's going to be gemcitabine within the next year or so because of a trial that was presented at the big American meeting in May, where gemcitabine is much better tolerated, there are fewer side effects than mitomycin, and appears to work as well. They weren't compared head to head, but and the other part of it is it's a lot cheaper. Not that necessarily drives it, but it really looks like it's better, and it just happens to be cheaper. The 1 year versus 3 year thing that I highlighted is relatively new, just around for the past couple of years. So it's important that that's done accordingly. Interesting thing I'll show in the subsequent slides, there's a lot of talk about different BCG strains. So BCG is a live attenuated bacterium that was generated however many years ago, and in different parts of the world we have different strains growing that are related to each other, but they're different. And different strains have been commercialized as different products for treatment, and it looks like there are differences in how they work, which I'll come back to. And then there are a lot of clinical trials for new drugs that I'll also go into. So this was a very interesting trial done in Switzerland. It's a relatively small number of patients, 149 patients with high risk, so high grade non-muscle invasive disease. They had 6 weeks only, so they didn't get the maintenance, but they only had the induction 6 weeks of either the Connaught strain or the Tice strain. Now the Tice strain is currently the only strain available on the market in North America. The Connaught strain was made by Sanofi Pasteur in Mississauga, Ontario, but they've gone offline. They've stopped manufacturing it, unfortunately. And what you see here is this is recurrence-free survival, that the Connaught strain is much better than the Tice strain in this study. So this is very compelling that there might be something there. It's not a big enough trial to change practice, and especially the fact that they didn't give maintenance treatment really means it's completely inadequate, but it's sort of a signal that makes it an intriguing idea. And so there is a big trial that has been launched in the US and will be launched in Canada as soon as the drug is approved by Health Canada for the trial. But it's basically taking, if you look up here, this first arm, so it's all patients prior to any treatment for high-risk disease. They have to be PPD negative. So this is the tuberculosis skin test. You have to be negative, because one arm down here at the bottom is actually getting vaccinated with the BCG strain. So the idea is that vaccination will improve outcome. So that's interesting. But the other two arms are comparing the Tice strain, which is the only one we have, with the Tokyo strain, which is a Japanese product. So we'll at least have a second strain in Canada. And the Tokyo strain in the lab is very similar to the Connaught strain. So there is some hope that Tokyo will be better than Tice. There's some hope that the simple skin vaccination will improve outcomes. So this is a trial that we'll be hopefully doing in the new year. Now, what happens when BCG fails? This is where it becomes a lot more challenging. On the one hand, the patient has non-muscle invasive disease, so it's still early stage. But on the other hand, we know it can progress and turn into something bad, and we know our tools to detect progression aren't that good. So sometimes it'll progress while we're watching it, and we sort of miss the boat and are dealing with a much worse disease. We know that if the patient develops muscle invasive disease before they go on to cystectomy, they will do much worse than, of course, if you get it before it goes to muscle invasive disease, but also compared to the patients who walk in the door with muscle invasive disease. So we really want to prevent that. So if we give more intravesical therapy, if we keep plugging away with more drugs, the risk of progression and death increases, death from bladder cancer. Yet if we push aggressively for cystectomy, we're potentially over-treating a lot of patients. A lot of patients have a lot of other medical problems. I told you that bladder cancer patients are older, and so cystectomy is not always an easy decision. It's a careful balance both for patient and for treating urologists. So what are the options? There are many options, and none of them are good. So none of these work very well. I always tell patients, actually based on this study, this was a cooperative group study, so big study, very well done, and patients got intravesical gemcitabine, which is as good as anything we can give. And basically, I always cite the number to patients that 20% of patients, if it's a patient sitting in front of me, you have a 20% chance of being disease-free 2 years from now if we plug away at various intravesical treatments. So the numbers aren't that good. So if you have a younger, healthier patient, they're going to tolerate cystectomy well, typically we'll do cystectomy. And if they're older, less healthy, we might try something else. I think it's reasonable to try one more round of something. You just have to be careful about doing it over and over again. The risk of progression goes up, the likelihood of success goes down, and it's a little bit of a game of Russian roulette. So there are a lot of drugs in the pipeline that are in clinical trials. There's a lot of clinical trial activity. 5 minutes, oh boy. I might just talk about non-muscle invasive disease then, but one of them, this is a virus that is put into the bladder. It gets into the bladder cancer cells and makes interferon, and interferon has an anti-cancer effect. It is probably the most likely to be approved by the FDA in the US and then eventually Health Canada within the next year or two I'm going to skip over some of these. Lots of interesting drugs. This is a local drug. This was developed by Helen Burt out at UBC. It's a sticky polymer, and you can load it with chemotherapy. So you put it in the bladder, and it basically sticks to the bladder wall and helps the drug get into the bladder wall more effectively. One of the problems we have now with the drugs is you put it in, it sits there for an hour, and then it just flows out again. And the bladder wall is actually a pretty good barrier. So this is a very simple concept, and this we're going to do the first in man trial in the near future. So muscle-invasive disease, just treatment options. Let me just run through this quickly. In general, the preferred treatment option for a patient with muscle-invasive disease is going to be chemotherapy followed by radical cystectomy. And of course, a lot of patients, about half of patients, are not really suitable for neoadjuvant chemotherapy, either general health, age, kidney function, or hearing, actually. Hearing loss is often an issue. So cystectomy by itself is also a good option. An alternative in patients with lower volume disease can be radiation with sensitizing chemotherapy. And if you really can't do anything else, then radiation by itself is better than nothing. One of the big things that I think is going to change in the next few years is our ability to predict response to the chemotherapy before surgery. Only 40% of patients will have a major response, and we think that only those 40% benefit, and the other 60% are put at risk for having side effects, and their surgery is delayed while they're getting this ineffective chemo. So wouldn't it be really nice if we could pick out the 40% ahead of time and only treat those 40%? And there are some promising markers. One is one that we've been working on here in Vancouver, and this gets a little bit complicated again, but we can classify bladder cancer into 4 groups based on some molecular factors. And you see they have these names here, but if you focus on the red line, which are the basal tumors, so about a quarter of tumors we would call basal based on their RNA. This is how they do without chemo. So this is almost 500 patients without chemo, overall survival. And then when you give chemo, look how the red line jumps up. So this group of basal tumors appears to benefit the most from chemotherapy, while the other lines stay where they are. So these two don't do so well even with chemotherapy, and the blue line does really well regardless of chemotherapy. And I'm going to skip over the numbers, but and then there are very specific mutations, so genes that are altered, and we know that these genes affect how a cell can repair damaged DNA. There's actually a whole panel of them. This is just one, the ERCC2, where patients who have a mutation and get chemo, they don't die. In this series, none of the patients died of their bladder cancer, whereas if they didn't have the mutation, they did, and there was a big difference. So if we can pick out these patients with a simple genetic test, that of course we can get these other patients, we can get them immediately to surgery, and we can do clinical trials and other things. So just in the last 2 minutes, it's hard, you can't do it justice in 2 minutes, but checkpoint inhibition. So immunotherapy in bladder cancer is really getting a lot of attention. It's maybe the one thing you don't need to hear here because you're going to hear it in the news anyway. But these so the checkpoints are molecules that regulate the immune system. So you can have immune cells that are all primed and ready to kill the tumor cell, but they're turned off at the last minute by these checkpoint molecules. And so the checkpoint inhibitors, the drugs, come in and they release those brakes and let the immune system kill the cancer. So let me just zip through this, because the interesting thing is there are a bunch of these drugs, and there are new ones every day. And there are 5 of them in bladder cancer, and all 5 of them have been tested in fairly big trials. And you might say, these are the response rates in patients, and it's around 20%. You might say, well, that's not that great. These are the most difficult to treat patients, so metastatic after the first line of chemotherapy, so the second line. But the remarkable thing is that those that do respond really have amazing responses, so durable responses. So on the left here in red are patients who responded to immunotherapy, and over here the patients who responded to chemotherapy, and this is called a swimmer's plot. And you can see, first of all, there are a lot more on the immunotherapy arm than the chemo arm. Sorry, I should have said this is a big trial where they compared immunotherapy to chemotherapy. But see, the green arrows mean the patients are still responding when the trial reported out. So most of the immunotherapy patients who've responded are still responding, Whereas the chemo arm, the black dot means that they've progressed and gone on to something else, or even died of their cancer. So it's, the big difference is, even though it's only 20% responding, those that respond really well. And as a result, there are 5 drugs approved in the US within a year, essentially, within exactly a year. And atezolizumab was approved earlier this year in Canada, durvalumab and pembrolizumab approved just in the last month or 2 in Canada. So these drugs are now becoming available for us as well in the second-line setting. And also in patients who are ineligible for cisplatin, first line, they can get it, although not in Canada. So, and these drugs are moving earlier and earlier through the different disease stages. So before and after surgery, for muscle invasive disease, and even into the non-muscle invasive disease. And we have a trial in patients here who don't respond to BCG that's going to launch in the new year. So it's exciting times in that regard. The future, of course, is all about combinations. So this is actually my last slide, so I zipped through it. So it is an exciting time in bladder cancer on many different fronts, but particularly the new treatments. I highlighted some of the new technologies that are letting us detect and treat bladder cancer better, especially the fluorescent cystoscopy. I didn't talk about robotic surgery. The molecular revolution, Alex Wyatt will talk to us a lot more about genomics and bladder cancer, but it is beginning to have impact. The studies need to still be done to prove that it has real clinical utility, but there's an awful lot going on in that regard. And then the new therapies are ultimately what it's all about for patients, and it's very exciting in that regard. So finally, bladder cancer is not the ugly duckling trying to catch up. Ken's slide that we're number 20 out of 24 cancers in research funding, even though it's number 5 in incidence, I think is changing. And hopefully we'll get a lot of progress in the next few years. Thank you.